I think in order for patients to get to the point where they're doing third party, they've already sort of had to feel like they've lost something. They've had to give up on maybe the dream of doing this with a partner. They've had to give up on the dream of using their own egg. And I think there's a little bit of mourning that comes to that to varying degrees. So I think once patients move on to third party, it's like, okay, well, I've already sacrificed kind of what I thought this was going to look like. Next part should come really easy.
From the Building Your Family community, this is the Building Your Family podcast. I'm your host, Lisa Schumann, author, researcher, and reproductive medicine therapist. As the leading destination for support and education for people using reproductive medicine to grow their families, we cut through the noise to provide you with research-based information, effective and actionable strategies, and the support you need to empower you to get into the driver's seat of your life and build the family of your dreams. We look forward to seeing you inside. Welcome to today's episode. We're glad you're here. Today, I want to introduce you to somebody special. Her name is Dr. Alexis Melnick, and she is a physician at Cornell Fertility in New York City, which is probably the most famous fertility center in New York and probably the world. And she's a brilliant, brilliant physician, but she's also a lovely person and has a wonderful story to share with us. So today you're going to hear a little bit about her story and a lot about her program, which is the Third Party Reproduction program at Cornell, and how she sees donors, what she thinks about the process, and some advice that you can take home and really use. So thank you so much for joining us, Dr. Melnick.
Thank you so much for having me. It's great to be here.
You mentioned before that you're open to talking about your story, which I think would be so nice to start out with talking to the viewers about, because I think it's so hard for patients to really understand their own process in comparison to everybody else because there's so much secrecy about it. So I really appreciate your openness. So perhaps we could start with how you got into third-party reproduction and your feelings about your own journey.
Yeah, sure. This sort of fell into my lap a little bit. I did my fellowship at Cornell, and obviously I was exposed to our donor egg program at the time. That was, most of third party at the time was really just donor egg. And Ina Scholz, who was running our program, was really a pioneer in the field. And Cornell really had, probably one of the first donor egg programs in the country. And she was going to be retiring. It sort of, came clear early on that I would have the opportunity to take over for her and take over for the program. And so we overlapped for several years, which was great because I got to learn from her, see how she was running the program, see what kinds of things she felt we should change moving forward. And then when she retired, it became mine. And there's been so many changes in the landscape of third party. So it's been really great.
It's so fascinating. So much to keep up with, so many new developments, right?
Yes. Yeah. And then my own story is that I, at the age of 39, decided to become a single mother by choice, which was something that was never on my radar. And I would say if I didn't work in this field and see this, see patients doing this and didn't have exposure to this, I don't think it would really have ever been on my radar, honestly. I now have two beautiful girls, a 2-year-old. My older one just turned 2 on last Monday, and my younger one is almost 5 months. So it's been, a pretty amazing and life-changing experience, but one that I never thought that I would do. I just never thought this was something that was for me. And you got to a certain point in my life and realized I want to have kids, and this was the best option for me at the time.
Wow, that's incredible.
Yeah.
And what was the catalyst for you? What do you think finally allowed you to say, okay, I'm going to do this? Because that's a big step in life.
For sure. I was never sort of gung-ho about having children. I was really interested in helping other, people build their families. It never felt like something that I had to do until it did, until just all of a sudden, I think one day was like, oh wait, no, if I don't do this, then that's going to just be, something I will regret forever, and something where I felt like all of a sudden I just had this drive that this is what I wanted. And I was lucky enough to have a practice where I was seeing single women coming in and doing it themselves and doing it with sperm donors. And they were amazing and had an amazing experience with it and no regrets. And I was fortunate enough that I was able to do it, that I had the support to do it, which is huge because that's such a challenge as well.
Yes, such a challenge. That's amazing. So, did your experience watching people kind of go through the steps of making the decision, then having to pick a donor, then having to go through the process and figuring out life, right? I mean, what are you going to do when the bouncy seat breaks and it's
Right.
raining outside and you have a cold and, whatever? You had to kind of figure all these things out. Diving into that, do you feel that watching the patients do that, though all of those details really helped inform how you were going to do it?
I think what I realized was, I mean, one thing I will say, and I see this from all patients, whether, regardless of how they choose to build their family, is it's so hard to be a parent and it's so challenging on so many levels. And it's like
Mhm.
nothing you've ever done before. And the one sense that I got was there are challenges that come with being a single parent, but there are other challenges that come with, co-parenting and having a partner. It sort of became very clear to me that this was going to be tough regardless of how I did it. And there's going to be bumps along the way, both ways, and different bumps depending on how I did it. I think that seeing what these women do this, though, just gave me a little bit more confidence
Mm.
about like, I will have a community out there. Because like you said, this is it seems more and more up and coming now, but even a few years ago, it just didn't feel like it felt a little bit lonely.
Mm.
So knowing I had this community and these women were, incredible, and they all came back and everyone said, I wish I had done this sooner.
Wow.
So,
That's amazing.
just very, very happy with their decision.
That's fantastic. Well, I'm
Yeah,
sure that people who are watching this are going to love to hear that because I'm sure it feels so scary when you get close to it. But everyone says it's such an incredible experience and so much better than not having done it. No matter how hard it is, it's always better.
100%. Yeah, 100%. I mean, zero regrets.
That's great. And so I guess that makes me wonder also, because we started talking a little bit before this about managing expectations, right? So, we talked a little bit about how hard it is for patients to manage their expectations because when they use a donor, it feels like, okay, that's the missing part that I need. Either I need a sperm because that's what I don't have, or I need an egg because my eggs aren't working. So once I fix that missing part, I'm good to go. I'm
Yeah.
ready to be 100% pregnant. And the thought of it not working seems impossible for a lot of patients.
Yeah, I think particularly with third party, I think that it becomes sort of extra challenging with expectations because I think in order for patients to get to the point where they're doing third party, they've already sort of had to feel like they've lost something. They've had to give up on maybe the dream of doing this with a partner. They've had to give up on the dream of using their own egg. And I think
Hmm.
there's a little bit of mourning that comes with that to varying degrees. So I think once patients move on to third party, it's like, okay, well, I've already sacrificed kind of what I thought this was going to look like. Next part should come really easy.
Hmm.
And it doesn't always because what we do is by no means an exact science and 100%. And that can be, even more devastating. So I think it's sort of like a double whammy for those patients where they don't have
Yes.
success immediately. I think you have to just go with data with patients and be really clear that, this is not 100% and it's not even close to 100%. I mean, that's, I think, what I find so incredible what we do is that if you look at, our success rates, in the best hands, you're looking at still a pretty significant failure rate. I mean, if we quote 70% chance of a live birth with an egg donor, well, that's 30% failure rate. That's pretty high. And if your heart surgeon's telling you 30% failure rate for some procedure,
Oh my gosh.
you're not going
No.
to that
Oh my
person.
gosh.
So
No. Yeah.
so I mean, I think it's really important to really early on lay that groundwork and just say this is by no means a guarantee, and it may be a longer road than you would like and than you expect.
Yes. And that's so difficult, I think,
Yeah,
right, for patients. And I remember when I started practicing almost 30 years ago, there was, I don't know, maybe a 30% success rate, not a
right.
30, right? It was the opposite.
Yeah,
And we were lucky for that, right? I mean, you were transferring day 3 embryos. So now it feels like this is amazing to have this. And yet it doesn't really matter. how much better it is. When you're the person going through it, it just is so devastating because if it doesn't work, it doesn't work. You're the
Exactly.
N of one. So,
Yeah,
right.
exactly. You're always the end of one.
Yeah.
And so it's very hard to, it's as much as you can give data and give statistics when you're that person in that, it's very difficult.
Yeah. So difficult. So how do you help patients understand that? And also, I guess, to the next step, when they start to think about choosing the donor, sometimes there's differences between them getting fresh, getting frozen. There's so many decisions to make along the line because I want to hear what you think about all those things. But certainly, first, the in terms of success rate, when patients are really focused on that, how are you thinking about counseling them?
I mean, I think it's about statistics to some extent, and it's about, your own individual clinic statistics and transparency. And, I will tell patients now, like you said, fresh versus frozen, like we, for the past several years, have had really equivalent success rates with fresh eggs versus frozen
Oh,
eggs, but that wasn't always the case. And I think,
mm-hmm.
that was something that was built into the counseling. So patients sort of understood that there were certain advantages to going with a frozen eggs, but, they did come with a little bit lower success rate. Luckily, we're not at that point now. I think really emphasizing the fact that there are a lot of other factors in this, and that even if the egg has been the biggest issue, if, for example, we're using egg donor, or if in the case of even using like a surrogate, if it's if these are not necessarily going to be cure-alls, and that statistically after a couple of transfers, the likelihood is you will have a child from this, but that it is not always a guarantee. And the other thing is that I think we can say, look, we've assumed this is probably mostly egg related, for example, if you're using egg donor, but we don't know. I mean, the ultimate test is going to be going forward with egg donation. And if it doesn't work, then there may have been other factors there. And that's rare that you get to that point where nothing is working, but it's always a possibility. So I think when I meet with patients about doing egg donation and I go through kind of success rates, I just make it clear that, it is for most patients that are going to this is what we know, this is the most successful option that's available right now, but it is, again, not a guarantee. And just trying to set those standards really like early on, and set expectations.
Yeah. What I find a lot in my practice and also in the membership program, people who are very anxious and they say, well, maybe I only want one child, but I'm going to ask my doctor if I can use fresh eggs because I'm really concerned about having backups. I don't want
Mhm.
to feel like now I have to go back and get more frozen eggs. And what if that donor is not available after I go through all the trouble of finding her? And so, how do you advise patients about those choices?
One of the first things that I will ask all patients is sort of what are your ultimate goals? Obviously, like I can't guarantee that we're going to get there, but if you could lay out how you want to build your family and in what ways, and how that would look in the perfect world, what does that look like? Because it gives
Mm-hmm.
me a sense of how many kids do you think you might want, how far apart are you going to want them spaced, sort of what's the ideal. And when it then comes to picking a donor, I also try to gauge how particular are you? How open are you going to be to various factors with the donor versus not? Because ultimately, I think finding a match can be really hard. And if you have a
Mm-hmm.
match, that's great. And we have an internal egg bank here. We don't use outside egg banks. So for us, if I say, look, we have an amazing match for you and a donor that's proven, but she only has 6 eggs frozen, versus somebody coming through who may we know maybe is going to produce many more eggs based on history or based on what we're seeing on reserve, but maybe it's not as good of a match. So I think it's sort of about gauging what's more important from a priority perspective. I
Mm-hmm.
think I also will ask patients about proven versus unproven. So some patients, it's very important to have somebody that has done this before and has had a good outcome. I mean, we don't really tell them the outcomes, but obviously if they're coming back, they had a good outcome. And I always bring that up as well. If that's important to you, think about this. That's something that we can sort of flag, because you will occasionally have a donor who comes through for the first time that does not have a good outcome.
Mm-hmm.
So I think a lot of it depends on timeline. I mean, there's a lot of factors involved. I really try to understand what the ultimate goals are. If it is somebody that's going to want multiple children, if it is somebody that is really dead set on doing PGT, which I know we'll probably talk about a bit more. I mean, that is somebody where I'd say, look, maybe a batch of 6 eggs isn't ideal for you. Maybe we should, do something where we think we're going to get more.
And what about that? What about using PGT? Because patients feel like it's kind of like getting in a car without the air conditioning, right? It's like,
Yeah. I'm torn on PGT in general. So my 2 daughters, I actually used eggs that I had frozen at 32, and I ended up doing a fresh, untested transfer with my first, and then I had one embryo that was normal, and ended up. So my second was PGT, and
wow.
So I have an untested and a tested child at home, and so far they seem pretty equivalent. There's a part of me that really understands patient drive for PGT, especially if you're going the donor route. It is again, you've gotten through a lot to get here. You want to feel like you're controlling as much as possible. And I understand wanting all that information. The data just doesn't really pan out when it comes to younger women, and donors are younger women. So I definitely think we see a lot of abnormals where they probably were not abnormal. I mean, if you just look at statistically, there are a lot of cases where we'll look at the number of aneuploid embryos we're getting, and it's sort of like, this doesn't really line up. And does that, is this real? We get a lot of mosaics. So you definitely lower your usable embryo pool by some extent, but it definitely gives more peace of mind. And you absolutely can do an untested transfer and have somebody who has an aneuploid embryo and ends up miscarrying. And that's kind of the worst, or God forbid, there's an issue with the pregnancy. So It's hard. I think we're doing it more and more. And a lot of that is mostly is patient driven, honestly. But if you look at the statistics and the data, it shows no benefit.
But I guess it goes back to the patient anxiety in some regard, right? That they feel like, okay, if I can check this box, there's one more thing I can do.
Yes. Absolutely. And I'm very much, I think I used to be much more like, absolutely not, don't do this. Now I'm much more like, I want to kind of, lean into what the patient is thinking, and sort of getting their, sort of getting a sense of how they feel, and how would they feel if they were to get pregnant and, God forbid, miscarry because there was a chromosomal issue. Or how would they feel if they have 10 embryos that are tested and they only find 2 are only normal and there's 4 mosaics, and what do you do with those? I mean, I think it's really different for every patient.
Yeah. Imagine your beautiful future. You're snuggling with your child. You feel so connected to them. Your friends and family are so happy, and you have everything that you've ever wanted. I want this for you too, but I want more than that. I want you to feel secure knowing that you've made the best decisions, not just short-term, but long-term for your future family. Wherever you are on your journey, whether you're choosing a donor, choosing a clinic, learning how to talk to your donor-conceived child about their origins, all of these decisions will have wider implications for your future. And I want you to have the right resources so you can feel empowered and confident at this very important time in your life. That's why I'm so excited to introduce you to Building Your Family. It's the only expert-guided platform designed for parents and parents-to-be using reproductive medicine. We provide unique strategies that you won't find anywhere else to make your path to parenthood smoother and more informed. And that's why our approach is about offering practical and actionable steps that you can use right now. Whether you're just starting out or already deep into your process, Building Your Family is here to guide you with expert advice, specialized education, stress reduction strategies, and a community to support you every step of the way. We can't wait to see you inside. Well, that's lovely. I mean, you're really thinking about each individual patient and their needs, because everyone's so different, right? And we all feel so differently about these things. Some people will stop treatment after one miscarriage, and other people will keep going, right?
Yes.
So, yeah, I think that's very thoughtful to kind of think about how the patients are feeling with regard to those choices.
I also find for a lot of patients, and to me, I'm always like, oh, what's a couple of weeks? For some patients, they're like, I'm in this, I'm doing this. I want to do this transfer immediately. I don't want to wait for testing. That's another thing that I find where I'm, to me, it's like, it's a few more weeks, but I think for some patients, like, nope, I want this now. I've been waiting. I want to do this. I want to be pregnant as fast as possible, hopefully.
Right. They want it to happen yesterday because they've been waiting. They feel like it should have happened years ago, right?
Exactly.
Yeah. And then I guess what I also see a lot of is when people have their heart set on a donor, particularly somebody that they know, they sometimes say, well, I really like this donor. So maybe she has fewer eggs. Maybe she's 36. Maybe there's these other issues, but it feels better than somebody I don't know.
Yeah. I mean, same idea, I think, is really about counseling of the patients. I mean, I think ultimately all of these interventions and the fact that we can do so much more and there's so many more iterations of what we're doing, it's all about just giving our patients more choice. And so I think it's great. I mean, I had somebody years ago who wanted to use her 44-year-old sister as a donor.
Wow.
Her 44-year-old sister was at OBGYN and said to me, I know 100% this is not going to work, but I know my sister really wants to do this and feels like she has to do this to kind of move forward. And that's, and she was told there's and the cycle ended up getting canceled for poor response. But she was made aware that, look, the chances of this working are extremely low, under 1% probably. And she felt like, look, for me to move to the next step of using a donor that I don't know, I need to do this. And so I think it's about just giving the information. I don't think I would ever really push somebody away from using a known donor if it's not going to be high risk to either party, because sometimes that's, even if that doesn't work out, that's like the stepping stone that they need to get to using an unknown donor.
So it's all really about patient autonomy and informed consent, right? Having the patients really understand what they're getting into.
Absolutely. And I think also understanding like that, because one thing that I think is people don't really realize until they do it is that, yes, it's known donation has huge advantages, but from an emotional perspective, especially like within families, sometimes it's you get them into group psych and you realize this is not going to work out well for anybody in this. So there's, as good as it might sound in abstract, when you actually start to think about logistics and then how are you going to look at the situation? How are things going to, what are the issues that might come up? Then a lot of times people realize, you know what, I don't think I want to do this.
Yes. It's so difficult, as we talked about when I was speaking with your group about my community platform. It's so difficult to choose somebody that you don't know.
Yes.
To be part of the most intimate part of your life, right? Of your family. So I certainly appreciate how people would prefer to use a 44-year-old sister, even if it doesn't make sense. But it's also got to be tough for you as a physician because you're looking at them thinking, well, I'm also concerned with you having a healthy baby.
Of course. And we're concerned about all parties.
Yeah.
We are one of the things that we do at Cornell that I think is really great is we are very careful. We make sure that in any cases of third party, that all parties have separate positions so that there's really no conflict of interest. So, in that particular case, the donor was my patient, the 44-year-old. And so, I felt like we made sure that, listen, we're not putting this woman at excessive risk. She understands what the risks look like, and I think that's really a nice thing that we do because and obviously the physicians work together, but it really makes sure that we're not missing something because it's hard. You want your patient who's a recipient to get pregnant. You want them to have the best chance of success. But then at the same time, you want to protect that donor.
Right. Protect the donor and also hope for, the healthiest outcome for everyone. Yeah. And do you find that there are situations I've had this several times where somebody wants to use, let's say, a niece or a cousin or something, and the cousin's feeling coerced, or maybe there's medical reasons why she shouldn't do it, or maybe she has never had a gynecological exam. It's hard because you're both serving the patient and the donor, right? You have to keep your eyes on both of them and their best interest.
Yeah, absolutely. We've definitely had cases like this where it is, and I think particularly family cases, and particularly family cases where there are outside influences on the family members. So we've had sister cases where mothers have gotten very involved. So it's hard. I mean, I think that's where having the separate physicians really can help because you can get a sense of, just talking to them as individuals and sort of get a sense of how they're feeling about it. And I think particularly when it's sort of different generations, so like things like nieces or even, significantly younger siblings. I mean, I think one of the first questions that I always have is, do you have a family? Do you want to have a family? And, I think if the answer is yes, I do, and I'm not, currently in a relationship or I'm not ready to do this on my own, why don't we think about what we can do for you first, potentially, if you wanted to freeze eggs? Is that something we always try to broach that subject as well? But I think that's where psych for us comes in. I mean, this is what you do. I mean, that's where this is so invaluable. And I mean, to me, is the most important part of the puzzle is really getting a sense of, because I think we can miss things in the consult with patients, and I think it's always interesting to hear what comes out in psych sessions with everyone.
Yes. Yeah. It can be so complicated. And unfortunately, when people use a donor, I would imagine you feel the same way, that they go into the relationship thinking, oh, it's going to be fine. There's not going to be any problems. And they don't think that, 50% of all marriages end in divorce, right? So why would this be any different, right? You're committing to somebody for the rest of your life.
It's so complex. I mean, I think these cases can be unbelievably complex. And you're right. I think people just don't realize till you're in it. And I think, again, bringing up like the different scenarios is really helpful with patients, because I always think it's amazing that like a lot of places have now gotten rid of doing psych, because I just think that
it's unbelievable.
It's scary, because there are just so many things that you wouldn't know to talk about, or patients wouldn't think about.
Yes, 100%. And sometimes those things don't come up for a long time. And then people come back to me years later and everything's a mess.
Yeah.
So it's great that you guys all support you, and you have such a great psychological team there where you are.
Yeah.
It's wonderful. It's really wonderful that your group is really, really protective of that, because it's so important, even though a lot of times patients don't feel like it's necessary. It's what really helps.
Oh yeah. We fight all the time with them.
It's a lot of pushback.
Yes. We really draw a very, very deep, firm line in the sand on that one. We do not, it's so important.
Yeah. It's so important. And speaking of, stress and emotional difficulties, when patients come to you, I would imagine very often, particularly heterosexual women, come in and it's so hard for them to grasp the idea of using an egg donor. It can be very painful and very difficult. And sometimes they may not be rational about the person they're choosing, because maybe this person has the same freckles as their mother and they want that person, but maybe that person's not as good of a candidate as somebody else. And so how do you manage that in the consult room with the patients?
I mean, I think really trying to be honest with patients. Again, I mean, I think ultimately, I mean, I come at this from the standpoint of, and I try really hard to tell this to patients, that, genetics are so bizarre and weird how they work. And, I always give an example of, I have a patient, she herself was Puerto Rican, her husband's Jewish, blonde hair, blue eyed. We spent so much time trying to find a donor that looked just like her and was a great match. And her child looks exactly like her husband. And she's always like, what, like, I love that we spent so much time doing this. Like, what was the point?
Right.
She always jokes like, great, my kid is literally my husband's clone. And he is.
Yeah.
So I think, particularly when you talk about physical traits, I mean, there are certain things that, like, yes, if you want a child that has light eyes, if you have light eyes and your partner has light eyes and you want a child with light eyes, for me personally, I really wanted my child to have blue eyes. I have blue eyes. I knew if I picked a donor that had blue eyes, that was going to happen. So fine, that's an easy one. But most of the time it is very complex. You don't know, and there's nothing that you're going to do is really going to guarantee anything really on that front. When it comes to sort of everything else, I mean, I'm just such a nurture over nature believer. So to me, I'm always like, your child's going to be who you raise them to be, and they're going to be the way that they are because of you, and because if you carry, we also know all of that epigenetic, stuff. And I think talking to patients about that as well is like huge when you explain that there are. You as the carrier, you are going to be, influencing so much of this child's genetics from day one. So that I think is really helpful for a lot of patients. But I think just kind of being honest, if I think one donor is a better donor for somebody, I'm going to tell them. I'm not going to demand that they use that person, but I'm going to, tell them what I think.
That's great. And then I guess the other question I was curious about, and I get this question a lot. Patients very often say, what can I do? I'm going to choose a donor. I'm going to the, Cornell's the best clinic. I'm going to do everything the right way. What could I do? And of course, you go on the internet and they say drink this concoction and, eat these things. How do I know what I should be doing to prevent miscarriage, to improve implantation, to, all of that? Is there anything that you would recommend patients do or don't do to improve their chances?
I would say stay off the internet, stay off Reddit, stay off Google. I mean, for sure,
Helps,
stay off
yes.
all of these. And it's very hard not to. It's a great question. It's like probably the question I get the most from patients, and understandably, because you want to feel like there's things you can control in this process. I am such a believer in like, just live your life. I really feel like you should just continue kind of on making plans, doing things, being social, doing the things that make you happy. I don't believe in really any supplements. I don't believe in limiting activity significantly after, during fertility treatment, if you're somebody who's an active person to begin with. I believe in self-care. I mean, to me, that is like the most important thing, is doing whatever you can do to take care of yourself. So if I have somebody who says, well, we kind of want to do a transfer this month, we're trying to figure out when to plan a vacation, like my first thing is plan your vacation, and we're going to plan your transfer around that vacation because you probably need the vacation. So I think that kind of stuff, things like acupuncture, my feeling is if you love acupuncture and it relaxes you, great. If you don't like it, go get a pedicure, go get a massage, like go have a glass of wine with your friend. I mean,
right.
I think it's really about taking care of yourself and not forgetting about yourself in this process, because it's like really hard not to become all consumed by all of this.
Yeah, very hard. And patients want the answers, right? They want the magic bullet, whatever it is that they can do. They'll stand on their head, they'll drink snake oil, whatever it is.
And I always say, like, if there was something like that, I promise you, we would tell you. Like, if I had something where I could say, do this and it will work, I would be telling everyone to do it. It doesn't exist.
You mentioned acupuncture. I know there were some research some time ago that it helped with blood flow and all those sorts of things. How do you feel about that for patients?
So, I mean, acupuncture's been around a lot longer than anything that we're doing. So I definitely believe there are tremendous health benefits. I think from a stress relief perspective, that's really where it's panned out the most. I mean, it's very hard to do good studies with fertility studies, in general. So although most, the studies have shown that it can be helpful for ovulation and definitely helpful for some blood flow issues, but, I wouldn't say there's anything that convincing out there. But I do really believe that if it helps with stress relief, then it's great. And I'm very supportive of patients doing it if they like it. I'm also kind of really a big believer in just trying things. So I think when patients bring it up, I'm like, go for a session and see if you like it. And if you like it, great. And if you don't, it's not for you. I definitely don't push it, but I think anything that can help with stress relief is good.
And what about after the transfer? Patients get very nervous, like, oh my God, if I step off the curb too hard, something can happen. And, people get very anxious about that sort of thing. What do you usually advise patients?
One thing that I found very striking when I was in training is that when our patients would leave the transfer, the room after the transfer, the doctors would be like, good luck. And again, I was like, okay, could you imagine, again, going in for some big procedure and your doctor was like, okay, we're going to go to sleep now. Good luck. I mean, it was sort of like, but I always will say to patients, so much of what's about to happen none of us have any control over. This is happening. It's in a black box, and there is nothing that you're going to do to make yourself pregnant. And there's nothing you're going to do to make yourself not pregnant. If it was that easy to control all this, I wouldn't have a job, right? It's so difficult. So I think, again, trying to just tell patients, like, you're not going to do anything. Now, if the other thing I'll say though is if you go and you walk 5 miles in the park, and then if you're not pregnant and you're going to say to yourself, it's because I walked the 5 miles in the park, then don't walk the 5 miles in the park. Know yourself and know what you're going to think about. But really, I mean, we know bed rest is not good. So I definitely say you want to be up and moving around and living your life. I think that weight post-transfer is the worst. I mean, for me personally, it was the most eye-opening experience because it was actual hell. Like, I mean, both times. Both my transfers. And I was lucky and I got pregnant after both my transfers. But I said, I wish I could be put into like a medically induced coma for these 10 days because it was awful. And I didn't expect it to be so bad. And I feel like I know the answers and I know the data, and I was a basket case. So I also really try to say to patients, this is going to be really, really, really hard. And, try really hard in advance to like plan good things for yourself to keep you busy and keep you occupied. So I don't feel that like you need to be sort of, in bubble wrap doing nothing for that time. I think being out and about, living your life. I really try to discourage people from like taking off time from work, because unless their jobs are so unbelievably stressful, I think not being in a routine and having all that time to sort of ruminate is terrible.
Right. And it's like that saying, a watch pot never boils, right?
Exactly.
That's how it feels, right?
Yeah, exactly.
It's like torture.
Yeah, that was for me. I was like, I really, until I was in that, I was like, I had no idea how awful that wait period was. And it is awful.
It's so awful. And patients get so anxious and they want to do something and there's nothing you can do.
And then they get anxious about being anxious. That's another thing I say.
Yes.
Don't get stressed about being stressed. Like if you're stressed and you're anxious, just lean into it, because it's not going to help to be stressed about it.
No. People get pregnant when they're stressed all the time.
Exactly.
Right? So, yeah. Well, this is great information and so supportive, Dr. Melnick.
Oh,
I really appreciate it. Really, really appreciate it. As we wind down, is there anything else you'd like to share with the audience?
Something that I say to patients, to anyone, and I feel very strongly at this, is that anyone who wants to be a parent will be a parent one way or another. I think it's really important to put that out there.
Yes.
Like everything else in life, it will probably not happen the way that you thought it will, because that's just life. But I think that is an attainable goal for everyone. It can be challenging. And again, it may look very different than you would have thought it would.
I agree 100%. And what's so nice, if you're willing to accept donor conception, it's really a matter of when, not if, right?
Absolutely,
it's a whole different experience.
Yeah. And the way that the field is moving, it just feels like we are just opening up so many more doors for people to do things and just, create all different types of family structures. And from the time that I started to what we're doing now, it's amazing. Particularly in New York, seeing, since surrogacy was legalized. I mean, it's just incredible.
Yeah, it really is incredible. It's incredible to watch all of it and to see how gametogenesis is happening and all of these other technologies are sprouting up and is going to make it easier and maybe more cost effective for people over time.
Absolutely. Yeah, it's just a great field to be in.
Yeah, it's wonderful. Well, thank you so much for joining. I really appreciate your kindness and your sensitivity and all your insights. It's great to have you here.
Thank you so much for having me, Lisa. I really appreciate it.
And thank you all of you for coming. I really appreciate it. I'm sure this has helped you. And if you like this episode, please press subscribe, because that's how we keep going. And I will see you next week. Hi, it's Lisa Schumann. I hope that you enjoyed that video and I hope it helped you. And if it did, please give us a thumbs up and subscribe, because that's how we keep going. It's really important to us. And if you liked it, you might like this one.